So my name is Brian Harry. I'm an associate or assistant professor of pathology. So I've promoted myself in pathology at CU Anschutz. Thank you to Marie and the rest of you for having me speak today. I'm not an active participant in cancer clinical trials in particular, but I have observed them over the years. And I think what my goal today is to talk about what's known as measurable residual disease in multiple myeloma. But the broader point for this group is to think about how we measure disease generally, and then what that means for the primary and secondary outcomes in the studies that you are participating in, especially as it relates to cancer. So we'll be focusing on multiple myeloma, but a lot of these principles extend to other trials, especially in the cancer space. I don't have any conflicts in this area. And these are kind of the things I wanted to achieve today. So first off, is just to give you guys an understanding for what multiple myeloma is. Most of you probably don't work with these patients specifically. And then to identify some of the methods we use to diagnose multiple myeloma. Some of these are transferable to other cancers. Some of them are quite specific to multiple myeloma. And then I want to focus really on what this concept of minimal or measurable residual disease is. And then finally talk about some of the emerging techniques. And again, some of these techniques are going to be applicable to other cancers as well. So for those of you who haven't been exposed to multiple myeloma, this is one of the most common hematopoietic cancers. So it's a neoplasm of the bone marrow. And traditionally, the definition of this is that there's greater than 10% of plasma cells in the bone marrow. What are plasma cells? So B cells, which are your antibody producing cells in the immune system, go on to differentiate into mature plasma cells. So most of us hope we have anti-SARS-CoV-2 antibody expressing plasma cells in our body right now that are pumping out potentially protective antibody from COVID-19, right? So this is the purpose of plasma cells, to create that large antibody repertoire that provides hopefully some neutralizing capability when you get exposed to an infection. However, in the case of multiple myeloma, you now have clonal expansion of an aberrant plasma cell that is no longer useful. And this does a number of things. So the first thing that it does is it results in clonal production of a single protein. So as opposed to having many different types of immunoglobulin, you now only really have one, which is not very helpful. And then in multiple myeloma, you also get a lot of end organ damage. This is one of the defining criteria for this disease. And so as you can probably imagine, these patients present with bone lesions that are associated with expansion of these plasma cells in their bone marrow. Because this is where red blood cells and other blood cells mature, these patients present with anemia because there's not really enough space for these red blood cell precursors to grow. And as bones break down, they release a lot of calcium. So this hypercalcemia, in addition to the high amounts of protein or immunoglobulin that multiple myeloma cells produce, puts a lot of stress on the kidney and can create renal insufficiency and kidney failure. Now, I'm not going to talk much about the ethics of clinical trials, but it is worth mentioning, given Marie's talk, that multiple myeloma is more than two times more common in African-American population than in Caucasians. And so this is an area where we have the opportunity, I think, to pay more attention to underrepresented and underrepresented populations, as well as those who've been taken advantage of in the past. And fortunately, there's been tremendous progress in this area over the past few years. So for those of you who are in the cancer space, you all have your favorite disease or the one that you hate most, perhaps, is the best way to think about it. And it might be represented on this list. So these are the incidence rates annually of new cases of cancer, and then also the number of deaths from cancer annually. So these are projected for 2021. Multiple myeloma falls somewhere in the middle of this. Leukemias are the most common hematopoietic malignancy, followed by multiple myeloma. There's some other blood cancers here as well. And the death rate here, you can see is, we're seeing about 35,000 new cases per year of multiple myeloma and witnessing about 12,000 deaths per year. And this number has actually improved dramatically over the past 2 decades. So chemotherapy was really the first line therapy for multiple myeloma in the early 2000s when autologous stem cell transplant was developed, and then a number of targeted therapies that have improved multiple myeloma progression-free survival and overall survival. So these numbers are looking better, even if they're scary on this slide. So how do we diagnose it? As we said, there's an expansion of these cells in the bone marrow. A normal bone marrow is represented here on the left. This is what's known as a bone marrow aspirate. And what you might see in a pathology report from a bone marrow like this is something called maturing trilineage hematopoiesis. So what this means is that the 3 primary lines of cells that go on to reproduce or to populate your red blood cells, your white blood cells, your platelets, these are functioning normally in your blood, in your bone marrow. So you see some variety of cell types in here. You see these dark nuclei. These are erythroid precursors, are red blood cell precursors for the most part. These cells here are your emerging neutrophils. These are the ones that are going to be released as soon as you get infected. And then you have a number of other progenitor cells here, including lymphocytes. There are occasionally a few blast cells in here. In a plasma cell neoplasm or multiple myeloma, this bone marrow largely gets replaced with plasma cells. And so these large blue cells with dark purple nuclei are the plasma cells in this image, and they have these 3 predominant features. One is an abundant cytoplasm. 2 is this nucleus that's off to the side, an eccentric nucleus. And then the 3rd is this, what's known as this perinuclear HOF, or this central clearing. Antibody cells' primarily responsibility is to, plasma cells' primary responsibility is to release antibody. And so these regions here actually consist of the Golgi body in the cells. If you guys remember those from cell biology, this is the part of the cell that's required for exporting proteins. And so as a professional antibody secretor, plasma cells have a very advanced Golgi body. So how do we diagnose this or follow this in the clinic? So I just showed you what happens when a patient who's suspected of having multiple myeloma undergoes a bone marrow biopsy, what that looks like. There's also a couple of techniques we use to further characterize and to monitor that disease. So the first thing is serum or urine protein electrophoresis. That's shown over here on the right. So this is a normal patient's serum proteins. As you probably know, albumin is really one of the most predominant proteins. There's some other characteristic fractions, but then immunoglobulins appear down here in what's known as this gamma fraction. And what you see from this blush, and also right here in this graph, is that there's a nice Gaussian distribution of polyclonal antibodies emerging from millions of B cells and plasma cells. However, in multiple myeloma, you get expression of a monoclonal protein. Again, you have this one predominant plasma cell that's undergone clonal expansion, right? It's taken up the whole bone marrow, it's causing kidney disease, release of calcium, et cetera, et cetera. And it's that plasma cell clone that is now pumping out the majority of antibody. So these patients now have a huge amount of monoclonal protein without much background polyclonal proteins or immunoglobulin. We can further characterize these proteins by a procedure called immunofixation electrophoresis. This essentially just allows us to say this patient has a IgG kappa multiple myeloma, for example. We can characterize it. And then in the past decade or so, additional studies have been performed to further characterize these proteins. So a serum free light chain and the serum free light chain ratio give us a sense for whether or not there's a normal distribution of kappa and lambda light chains in the blood. So for example, a patient who has a lot of IgG kappa due to multiple myeloma will have a very high free light chain ratio. So these are different ways that we have traditionally measured multiple myeloma. However, there's a huge problem with this, and that has been what we have been calling a complete response. So if you take this method that we just talked about, immunofixation, and you use that as the defining feature, you can dictate when a patient has become negative for a monoclonal protein in the blood and the urine because you can't see it anymore. Another aspect of this is if you do a repeat bone marrow biopsy, you now have fewer than 5% plasma cells. This is how this disease used to be defined. what we found over the past 2 decades as therapies have improved is that we're telling patients they have complete responses, but they relapse at a very high rate. And so what that means is that we're largely not seeing minimal residual disease with our current methods. So the International Myeloma Working Group further developed complete response to a stringent complete response by adding in some additional measures. So one is that free light chain ratio that we just talked about. Another is doing additional workup on the bone marrow to show that they're clonal plasma cells or that they're polytypic or polyclonal plasma cells. However, even with these additional criteria, there's still a tremendous number of patients that undergo stringent complete response, but have relapse. So more than 50% of patients in recent trials still fall into this category where it looks like they're completely responding, but then they're back relapsing at another time. So there's a lot of problems with this. The first thing is that we're telling individuals that we don't see disease when we know they have it, we just can't see it. And the second thing is that it's very hard to give patients a prognosis about whether or not they're going to relapse when it's essentially a flip of a coin, right? So we need better methods and better definitions of what minimal residual disease is in order to help patients understand their likely disease progress. So as we're kind of alluding to, that this idea of minimal residual disease really comes down to how little can you measure or how little can you find, right? The classic needle in a haystack problem. In multiple myeloma, minimal residual disease has now become a primary outcome in multiple myeloma trials. So in addition to things like progression-free survival, overall survival, this is something that study investigators are now really expected to look at to understand the efficacy of their therapies. As we said previously, MRD negativity was defined by the absence of plasma cells, but now there are new techniques. So it's not just about whether or not there's fewer plasma cells in your bone marrow based upon traditional methods. There's now other minimal residual disease techniques to use. So one of these is known as flow cytometry. Another one is next generation sequencing. You've probably heard of these technologies on some level in the past. Their applications to multiple myeloma have really grown up in the past 10 to 15 years. So flow cytometry is a method where you isolate cells and then you stain them with specific markers that recognize proteins on the cell surface. And then you pass those cells essentially through a light instrument that can detect which markers are lighting up on those cells. And so you get some sort of population that defines a cell of interest. So this, for example, is a pattern that marks plasma cells. There's some major pros to this method, which is that you can now get a sensitivity to 1 in a million. So if you're able to get a bone marrow biopsy that contains a single plasma cell out of a million, you'll largely be able to detect minimal residual disease. However, there's problems with this, right? The patient still has to undergo another bone marrow biopsy, which is really not fun every 1 to 3, 6 months, depending on where you are in your disease. There's also major problems with sampling, right? So we saw before a patient getting a bone marrow biopsy from their iliac crest, but where is the patient's disease, right? Where are you going to sample, and are you going to capture disease in that sample, or are you going to miss it? So for individuals who have patchy disease or they have extramedullary disease, that is disease outside of their bone marrow, this method is susceptible to missing that. And another problem with this is that this tissue needs to be evaluated in a fresh manner and immediately. So it's nice because you get results quickly. It's a challenge because you need to have the resources immediately available to give these results back to the patient appropriately. Next generation sequencing is the other method we mentioned, and just on the face of it, it's generally performs very similar to next generation flow, but the principles are quite different. So the idea with next generation sequencing is that you really want to understand the DNA sequence that's associated with these individual plasma cells. However, this isn't like next generation sequencing that you might see in lung cancer, for example. If you're looking for a KRAS mutation or other typical mutations, what's unique about the mutation here is that it's specific to that patient's multiple myeloma. So every patient's multiple myeloma genes look a little bit different, right? So you can't set up a single assay and then run that on every multiple myeloma patient. What you have to do is you have to look specifically at that region in the genome where the plasma cells have rearranged DNA. So if you think about the immunoglobulin genetic coding regions, there's a couple different regions in the cell. Most cells don't touch this at all, right? Most cells just leave this alone. They don't express any immunoglobulin. B cells, of course, do. And as they undergo development, they piece their genes together in different ways to increase the diversity of the antibodies that they make. And so ultimately, the plasma cells will have a very unique combination of what's known as these BDJ and BJ arrangements. So these are just regions of those immunoglobulin genes that get rearranged. And ultimately, they define what's known as this complementary determining region. The only reason I mention this is because this is the part of the antibody that really determines what the antibody sticks to, right? So if you've gotten your COVID vaccine and you're hoping you have neutralizing antibodies to SARS-CoV-2 virus, it's this region that will recognize the spike protein of a SARS-CoV-2 virus, right? So this is where the specificity for each antibody comes from. And for an individual multiple myeloma patient, it's the signature, their genetic signature for their disease. So similar to next generation flow, it's got great sensitivity, right? 1 out of a million cells, you can pick that up. However, there's similar problems. The same two that we discussed for next generation flow, patients still have to undergo biopsy and they still have problems with patchy disease or random sampling. Specifically also for next generation sequencing, it requires concentration of the sample and lots of DNA, and it's also very labor intensive. As this group is probably aware, managing clinical trial information and the infrastructure that's required for that and dealing with that, it's similar when it comes to bioinformatics data and analyses. There's this huge pipeline that's required, a lot of expertise and a lot of resource support that's necessary to execute. So again, this is a technology that's not available in many settings. However, as we said, the sensitivity of next generation sequencing is quite good, and it's actually quite comparable with next generation flow methods. So what that means is that if you take a patient and you harvest their bone marrow and you run some of that bone marrow by flow cytometry and you run some of that bone marrow by next generation sequencing, most of the time, if one comes up positive, most of them will come up positive. Occasionally, that's not the case. And so this is slightly further comparison between these two methods. And what I want to do here is just to outline some of the major differences and where we still need to make advances. So fortunately, these are applicable in the vast majority of diseases, and they have very similar sensitivity. Next generation flow, as we said, has to be done quickly, right? And so, but you're also going to get results more quickly, whereas next generation sequencing, you have to wait. So, if any of you have a family member who's gone through cancer, and especially in the context of a clinical trial, the oncologist knows that starting therapy today is not going to change very much. But the patient sitting there knowing that they have cancer and awaiting therapy is an extremely anxiety-inducing period. And so the same is true here. If you're waiting a week, 2 weeks just to get results back, this is going to have a huge impact. So while these methods technically are comparable, many patients would probably prefer to know within a few days whether or not there's likely a relapse of their disease. Both of these methods are very quantitative. They allow us to characterize either the cells or the genetic sequences themselves. They have a variable amount of availability in settings. Even next generation flow is not accessible outside of many large hospital settings. And then another thing that I think about a lot as a clinical pathologist is whether or not these assays are harmonized. So what this means is that if you have a patient who's being treated at Memorial South and they have their creatinine tested by one method, and then they come up to Anschutz and they have their creatinine tested here, are those two comparable, right? In our system, creatinine is comparable, but that's not true for every test at every place. And so if you have a patient coming from Dana-Farber or Memorial Sloan Kettering who's had one of these methods performed and now they're coming here, how do you interpret that in the context of data that we're providing our oncologists in this setting? And so that's what harmonization means. And next generation flow cytometry has come a little bit further in that regard in terms of the data being kind of transmissible from location to location. I'm a pathologist, so I think a lot about objective measurement of disease, but I am not a radiologist, and so that's my disclaimer here. But there is another important aspect of minimal residual disease testing in multiple myeloma, and that's the PET-CT scan. So we mentioned earlier on that one of the defining features for multiple myeloma is bone disease and lytic lesions. Many times these show up on normal radiographs or normal CT scans. However, not always. So what PET-CT can do is identify metabolically active lesions. And what it can also do is it can identify disease regardless of whether or not it's patchy and regardless of whether or not it's actually in the bone marrow. So unlike next generation flow and next generation sequencing that depend upon bone marrow sampling, PET-CT can kind of give you a whole body evaluation. And here's just one example of a situation in which this is really important. So at the top here, we kind of have a full body PET-CT scan. And here we have the CT scan of the patient's femurs. And then here is adding the PET piece on top. So this black dot here is an area where there's highly metabolically active tissue, and in this case, representative of multiple myeloma. So there are circumstances in which imaging modalities are really important. You can imagine how this would have been completely missed by doing bone marrow biopsy, right? So, so the goal here overall is to assess the deepest level of therapeutic response. And we have a couple of different ways to do that. We've talked about next generation flow cytometry. We've talked about next generation sequencing. And then right now, the International Myeloma Working Group, it recommends actually that we use PET-CT as well as one of these other two methods to look for minimal residual disease. So that if you're involved in multiple myeloma at all, these are the types of outcomes you're going to see in your trials. Let's skip this one. There's one other emerging method that I wanted to talk about, and this is mass spectrometry-based detection of minimal residual disease. So there are some advantages and disadvantages of this. And before we get into those, I just want to kind of walk you through what it takes to do this. So when you have a multiple myeloma patient, there's generally an early diagnostic sample. And that sample can be used to find the sequence of the patient's very unique genetic alterations in their plasma cells, which then can be used to predict the proteins that are made that comprise the antibody or the monoclonal protein in disease. And in doing that, you can take this sequence to predict the peptides, and then you can design an assay to look for those peptides in a mass spectrometer. We're not going to talk about what mass spectrometry is, but imagine for a moment that you know what the sequence of the antibody is. This is an antibody here. You take a protease and you chop it up, and then you put those peptides into a mass spectrometer. And you will be able to detect, if you've had that patient's initial sample and you've characterized it, you can detect how much peptide there is over time. So again, peptide is the part of the antibody that you want to detect, and we're able to do this based upon the original sample. The difference here, however, is that you can do it in the blood. After you've done it in the bone marrow first, and you've characterized this, you can then proceed to do it in the blood long term. So what this would mean is that instead of undergoing bone marrow biopsy on a regular basis, patients can come in and give a blood sample and then come back later, right? I don't want to go into the details of this trial. I think I probably missed the mark for this group a little bit with this talk. So what I just want to focus on is this concept over here. So what this Kaplan-Meier curve discuss, everybody here knows what the Kaplan-Meier curve is, so I don't have to go there. But the focus here is that there's two different methods for minimal disease detection. There's next generation sequencing, NGS, and then there's mass spectrometry, which I just kind of highlighted. In the case of these being positive, black and red, you can see that patients who have one of these methods that's positive, they have lower overall survival, right? These curves drop more steeply when one of these is negative or one of these is positive. When one of these is negative, the blue and the green, you see that survival is slightly improved. And you also see that they're somewhat comparable, right? These lines cross over each other. However, when you use both of these methods simultaneously, you're able to identify a population that has much longer progression-free survival. There are some indications that maybe mass spectrometry is slightly better. So for example, the 50% progression-free survival mark was 89 months as opposed to 69 months. But the overall takeaway from this is that having multiple methods to detect minimal residual disease in myeloma is going to be particularly important for risk stratification. And that principle is going to carry over to other cancers as well. So while this may not be particularly interesting to you now, I do think there will come a day when you will see these types of technologies used for primary outcome endpoints. Okay, so where do we stand now? We talked about early on how we can look at the proteins in your serum to diagnose and characterize multiple myeloma. Unfortunately, we need to see a lot of proteins to use these traditional methods. So protein electrophoresis has been around for half a century or more. With that method, we can see about 10 grams per deciliter. And this is similar to Marie was talking about before. You don't know how many tons of HeLa cells this is, but relatively, this will make sense, right? So protein electrophoresis gives you 10 grams per deciliter. When you do immunofixation, this was a method we referred to earlier but didn't really talk about, you can get another order of magnitude more sensitivity, right? So now it's 0.1 instead of 10, so 2 orders of magnitude. And then if you incorporate mass spectrometry, again, we're talking about this because this is the blood, not the bone marrow, right? If you incorporate mass spectrometry, you're now looking at 10 to the 4th grams per deciliter. So from here to here, we've now spanned 5 orders of magnitude increased sensitivity using a blood sample rather than a bone marrow sample. So the general advantages for mass spectrometry-based minimal residual disease is that there's exceptional sensitivity compared to other protein-based methods. And there's comparable, if not improved, sensitivity compared to these other methods for minimal residual disease, next generation flow, next generation sequencing. Again, I showed you one piece of data earlier about how next generation sequencing and mass spectrometry were actually very complementary. The key here is that you can use blood instead of bone marrow to monitor for disease. And there's another great feature here, which is that you can discriminate between the antibody that's pathological versus a potential antibody that's being used therapeutically. So almost all therapeutic antibodies are what are known as IgG kappa antibodies. So that means they have a IgG heavy chain and a kappa light chain. And there's a big problem when you're on one of those antibodies and your pathologic monoclonal protein is IgG kappa. Sometimes it's very difficult to distinguish those with traditional methods. So this is another huge value add if this method were to come online. We kind of talked about the pitfalls of traditional MRD testing. Some of these mass spectrometry is an advancement over. So the bone marrow biopsy sampling is a problem. Mass spectrometry is going to go for peripheral blood. So that's a potential advantage. There's also these other issues though, where the MRD negativity, being able to detect minimal residual disease may actually change from day to day. This is similar to, like, let's say you had a very low viral load COVID infection, right? You get tested in the morning, you're positive, afternoon, you're negative, night, you're positive again, right? So when you get down to a level where the signal is near the assay cutoff, you can have a transient positivity or negativity. Patients with persistent MRD have prolonged progression-free survival. So that's something we've seen with both the new methods and the emerging methods. And then finally, one of the other issues is that when you have disease that's extramedullary outside the bone marrow, you will often miss this with bone marrow sampling techniques. So I want to thank you guys in advance for bearing with me through this. Again, I think I missed the mark for this group. But the takeaways that I want you to hear from this are that one, that multiple myeloma has seen tremendous progress therapeutically over the past 2 decades. This largely has to do with stem cell transplant and new targeted antibody-based therapies. Part of the reason that has occurred is because of our technologies for minimal residual disease testing, which have been able to increase the sensitivity at which we can detect plasma cells, their DNA, or their protein from both bone marrow and peripheral blood. Those methods are next generation flow for the cells, next generation sequencing for the DNA, and then mass spectrometry for the protein. Again, the cells and the DNA from the bone marrow and the protein circulating in the blood. So this, again, is one of the major upsides for mass spectrometry. And then, as with most methods, parallel use of these and complementarity of these methods is probably going to be the most helpful in identifying patients and their prognosis. So I want to thank you for your attention, and I'll also say now, I'm happy to talk more about multiple myeloma in the context of trials or discussing minimal residual disease for those of you who are cancer investigators.
You didn't miss the mark at all. That's kind of really what I wanted. But I do have a couple questions. So if you, and I'm a non-clinical person, so I'm going to start with that. So if you can identify lesions on PET-CT, would you not use the PET-CT to determine where you want to get the bone marrow from? I mean, can't you get bone marrow from the femur? Or is it just too much hard? Is it just too hard to pull from where somebody's lighting up?
It's a good question beyond my professional scope. But what I will say is that most of the time you use imaging methods to target a lesion. It's ultrasound guided, or for example, a method called MRCP. If you're going to
right.
You can use MRI-based sampling methods. To my knowledge, there's no method that is a CT-based method that allows you to direct your biopsy instrument at the same time. That's not to say, however, that you couldn't do a PET-CT to get an idea for where it is. However, in a patient with multiple myeloma, especially one who has responded, if they have lesions showing up in their marrow that are metabolically active, most likely that's related to disease. So that will be considered a recurrence, I believe, even without repeat biopsy. So if you see it on PET-CT, okay, it doesn't necessarily need to be repeat sampled.
Okay. Yeah, my cousin died from multiple myeloma back in the 80s.
I'm sorry to hear that.
It's a terrible disease.
Yes, it's still incurable.
Yeah. Anybody got questions? This group isn't really this quiet.